we move ahead with the WCCPCI 2012 Dr. S.K. Parashar oration. This year, this is being conferred on Professor I.B.Vijaya Lakshmi from Bengaluru. She'll have 15 minutes for the presentation, and then we'll have 3 minutes for the oration protocols. May I request Dr. Chopra and Colonel Parashar to please take over the proceedings.
I'll request Sonia and Hala to please come on the dais. This is a echo oration. Please come on the dais. Sonia, Hala, and Mrs. Rick. Mrs. Rick, can you come? Is it possible for you to come? Dr. Seth. Dr. Seth. Ladies and gentlemen, I would just like to mention a few words about this oration. It is a very prestigious oration. It took me a lot of time and our committee to convince Dr. S.K. Parashar that we should have an oration on his name. He refused. As usual, he's an army man, and he said, I am very young to have an oration on my name. It is usually post-mortem. Why should I do post-mortem? We want to do an oration when he's alive. He should see that he's a young Indian father of echocardiography, and we are very proud of him. Because I've seen him for the last 30 years, how he has evolved echocardiography in India. We are overwhelmed and highly emotional for the contribution which he has done to India and to the world. Let's give a big hand to Dr. S.K. Parashar. And this oration is on his name and is bestowed upon a lady, I think, who needs no introduction to the audience. Where is she? Vijaya Lakshmi. Vijaya Lakshmi is the most beautiful lady in pediatric cardiology. When I say beautiful, not only at a look, a beautiful mind. And she is a beautiful contribution in the pediatric cardiology. You've seen on the day one, the book released, rheumatic heart disease book published by her. She has tremendous contribution in the whole globe. Yet she is very humble, very subtle, and no agitation and no show off. Very simple, very humble. I have no words to express. I feel very highly privileged for her to accept our invitation for this particular oration. Before I really invite Vijaya Lakshmi to give this oration, it's my humble duty, all the chairperson, to kindly come in front, along with the young echocardiologist, Dr. S.K. Parashar, on whose name is this oration, to kindly bestow upon this oration to Padma. The subject she is going to cover is a very, very important subject, and that is echo-guided intervention in pediatric cardiology. A very new, emerging subject. She has a tremendous experience. Vijay, time is now.
Yeah. Good morning, good afternoon to respected chairpersons and dear delegates. It's my proud privilege to deliver the first Dr. Parashar oration. The topic is echo-guided interventions in pediatric cardiology. And Dr. Parashar, in one word to say, he is a great natural source of vitamin I and E. I stands for inspiration, E stands for not just energy and encouragement. And he has done that abundance not only to me, to many youngsters like me. Sir, it is my proud privilege to deliver the first oration in the name of the great source of vitamin I and E, that is Dr. Parashar. Intervention is to come between in order to stop, settle or modify. That is the definition of Oxford Dictionary. But when it comes to intervention in cardiology, it is intervention in pediatric cardiology is to come between the heart disease and the children and their death in order to stop the progression of the disease or to modify or to change the course of the disease, and that I'll show you during my delivery. Echo plays an important role in selection of the cases as well as during the procedure and after the procedure and also during the follow-up. Among the greatest achievements in the cardiovascular medicine in the past century has been the advent and development and refinement of invasive diagnostic and therapeutic modalities of cardiac catheterization and interventions. But echo comes as hand and glove, and it is a great source of support as adjunct and also for the improvement and the better quality of work that we can turn out. This is a great guy, Kurt Amplatz, who is the inventor of Amplatz device which we use. And here you can see that it is the atrial septal device, and this has got 7 millimeter retention skirt on either side, and that is the waist, and that is the one that we use for the aortic closure. And when we take a subcostal view, not only that we take how long is the intra-atrial septum, how much is the rim, the inferior and the superior rim, and how big is the atrial septal defect itself, so that we decide how much to, what device to be chosen. And this is very important to know that what is the rim of the aortic rim, and we should not make a wrong measurement, so that if the aortic rim is very small and if we put a very large device, it can lead to the erosion of the device and the late complication of pericardial effusion and death, and hence the aortic rim has to be measured very well. And this is a modified subcostal view, which is almost like akin to the transesophageal view that we get in the adult, and in children we can get beautifully, so that you can see how the superior inferior rim and how big is the AST, whether there is a septal aneurysm, whether the septum is flimsy or it is thick and it can hold the device or not, all can be assessed in this view. And this is exactly when we put the device, this is how it looks on either side. The left atrial disc is on the left atrium, right atrial disc is on the right atrium, and whether the septum is right in between, it can be measured, it can be exactly seen on the echo, and that's how before we release the screw, the echo plays an important role to make out. It is much more accurate than the screening that we do. And not only that, when we go through the subcostal, we can get the superior vena cava, whether the device is obstructing the superior vena cava also can be decided by the echo. And apart from that, whether the mitral valve, tricuspid valve, all those things are free. More important is, here you can see that the multiple clots are there on the device. If we see the multiple clots on the device, that means the ecosprin as well as aspirin as well as the thrombolytic thing, that is the heparin, is not adequate, and we have to put the patient on heparin for the next few days, otherwise we end up with the catastrophe in spite of doing the good device closure. So this is how the echo helps us a great deal as to make out. And here you can see that in the same patient we have put an apical VST as well as the AST close in the same sitting, and what is important is how many more VSTs are left, whether they are small, big, hemodynamically significant or not, can all be assessed by the echocardiography. And here you can see that though the device looks all right, there is a residual shunt, the residual AST is there, and there are multiple VSTs left, but they are all very tiny. So that shows that here the two devices are adequate, and then echo plays a role to decide whether the two devices are enough or not, and whether anything else is required. When from AST we move on to the patent ductus arteriosus, this is how the duct looks, and that is how it is, and this is the device, and there is no residual shunt. The echo plays an important role to find out whether it's a tiny PDA, whether a coil is required or the device is required. And when we go to the ductal view, we can literally measure the ampulla and the narrow portion, and then we can decide whether what size of the device is required, and this is how the echo plays an important role. And here, the young child, 10 months old child, you can see that there is an AP window, and here you can see that from the aorta to the pulmonary artery, directly the shunt is occurring. And this is a difficult cup of tea, and here you have to assess the pressures, and then you can see that echo plays an important role after the device closure, before the device closure, and you can see that how the device is perfectly sitting between the aorta and the pulmonary artery without any residual shunt. So echo helps us to decide what size of the device, where to put, how to put. And this is a very rare condition that's called as a Garbude shunt, where the VST is from the left ventricle to the right atrium, and this is difficult for the surgeon to close because it's very close to the conducting system. The moment he takes a bite, the conducting system can lead to the complete heart block. And here you can see that how beautifully the device is sitting between the left atrium and the right atrium, and without causing any tricuspid regurgitation, and this is how it can help us. And here you can see that there is a large VST with a tunnel-like thing, and this is how the device is, and without the echo we would have lost this patient. And what happened is, within the next few minutes, as the sheath was taken, to our utter shock, the blood pressure started dropping, and there was a severe bradycardia which was not responding to the atropine that is usually given for the vasovagal effect. And here, what was the cause? We couldn't make out until we did an emergency transthoracic echo. Now you can see that in the echo, the IVC is dilated, and there is the dilatation of the right atrium bulging, and when you can see that gradually the right atrium started bulging and the right atrial size went on increasing. And before we could decide what to do, when we went ahead and did the color Doppler, we could see that the tricuspid valve was blocked. There was a severe tricuspid stenosis as well as tricuspid regurgitation, and the gradient across the tricuspid valve was as high as 30 millimeter, which we have never seen in even the rheumatic heart disease. And this was now or never, do or die situation, and we could see that the RV disc of the ventricular septal defect, the device was almost caught and blocking the whole of the tricuspid valve, and whether to send for surgery, what to do was a problem. The OR was not ready, the surgeon was not ready. So what we did was, we knew that we dilated first with 12/40 and then inflated the balloon across and then just tried to push it, and then the device fell down. So where the device fell down, we couldn't make out, but of course echo was very handy for us, and you see the whole thing, the end of the nightmare occurred. The device was perfectly in the right position, and this is how the device is in the position, and the check angio shows that the device is all right, and the check echo shows that the device is no more blocking the tricuspid valve. There is no tricuspid regurgitation, no tricuspid stenosis, and that's how the echo helps us to overcome the emergency that occurs even in the cath lab. And here you can carefully look at the device. It's a large 24 millimeter VST septal defect, and you can see that something is fluttering inside the device. That is because I have made two fenestration. This was a patient with a severe VST with a severe PH. Surgeon was not ready to operate upon. I made a two fenestration and put a 24 millimeter device, and that is the fenestration. You can see that the holes and the flow is across that, and the patient made a good recovery. Echo not only helps us to decide what device to put, when not to put. When you have a large vegetation like this attached to the ventricular septal defect, this is not the patient for the device closure, so the exclusion criteria also can be decided on this. And this is the non-compaction where multiple VSTs were there, and this is the apical to ADO2 device in the apical position, and then the patient made a good recovery. In the same sitting, we closed the PDA also because he had this 8-month-old child had a large PDA tubular closed with the ADO2. So 2 ADO2s, and the echo shows very well. The echo not only helps for the device closure and also for the other interventions like pulmonary stenosis. Here you can see that the annulus can be clearly measured, whether it's a dysplastic valve, bicuspid valve, whether the valve is balloonable, whether we are going to get suboptimal or good results, all can be made out by the echo. And as small as the newborn baby, even as less as 1.8 kilos, we can see that literally there is no flow into the pulmonary artery, and we can decide whether this child requires balloon or not, and that decision depends on our echo itself. And this is here you can see that in the parasternal long axis, a beautifully doming of the aortic valve and the hypertrophy. And once you have a doming and the hypertrophy, and that is the bicuspid aortic valve you see in the apical 5 chamber, get the gradient across, and then you see that the bicuspid valve is opened after the balloon dilatation. Now, the echo plays an important role to decide what is the gradient. This is one rare patient where the gradient across the aortic valve was 242, and echo showed that there was a very critical stenosis with just 4 millimeter cusp separation, and this required the balloon dilatation, and that lady delivered well afterwards. But echo also helps. This is one patient who had the gradient was very high. We took for the balloon dilatation, and on the cath lab we realized that there was the LVOT obstruction rather than the valvar, and everybody felt that balloon dilatation should not be done. But what had happened was, once the anesthesia is given, because of the hypertrophy, it appeared to be there is more of a dynamic obstruction in the LVOT. The valvar was missed, but echo clearly showed that it was more of a valvar gradient, and that's how I went ahead and did. And like how you have an infundibulous stenosis, you can also have LVOT gradient when there is a severe stenosis. So echo helps us to distinguish whether it is a subvalvar, valvar or supravalvar. This is a cooptation where you can make out that what is the narrow portion, how much is the post-stenotic dilatation, what size balloon to be taken. And in even rare conditions like non-compaction and the aortoventricular tunnel, this is the first case to be closed with the device in the world, and you can see that with the echo itself we made the diagnosis and closed it. And followed to that, we had one more case. Here you can see that there is a big channel coming out from the aorta, and one may have a mistake what it is, whether it's a coronary AV fistula or what it is. Now you can see that an extracardiac channel is coming and opening into the right ventricle, and that is the aorto right ventricular tunnel, and this distinction can be made very well in the echo. The angio does not help us, but echo does help us to see the coronary separately and the tunnel separately. And here you can see that that is the tunnel. At the end of the tunnel you have an ADO tube beautifully sitting there. So we were the first one to close the aorto left ventricle as well as the aorto right ventricular tunnel with the device and extracardiac channel. And here it is more than 90% of them communicate to left ventricle, and very few of them they communicate to this thing. So incidence is less than 0.05%, and echo helps us very clearly, very lucidly tells us what exactly it is. So this is the 7th case in the world, but to be closed with the ADO2, a first one. Not only the congenital heart disease, the common, the rare conditions, all can be diagnosed and managed. The echo plays an important role, and rheumatic heart disease, especially the juvenile mitral stenosis, is extremely important in our country. Can anyone make out what it is? This is the surgeon's finger that is trying to poke into the mitral valve, and this is how they used to puncture the apex of the ventricle, and then they used to put the dilator inside and try to do the closed commissurotomy in the past. And this is very difficult in the children, because if they require restenosis and redilatation, and once they have tied the appendage, it is not possible for them to do the closed balloon dilatation. So today we have a wonderful balloon dilatation, that is the PTMC. Now you can see that we puncture the intra-atrial septum, especially the pregnant women, we can cover the abdomen and puncture it, and that's how the valve looks almost closed and hardly it is opening, and that is the balloon dilating. So without even fluoroscopy, without radiation to the fetus and the mother, we can dilate, and if we are not happy with the dilatation, we can go ahead and dilate it further. And this is exactly, the echo plays an important role to assess before, afterwards, during the procedure, whether it is a surgical procedure or the intervention. The echo is a must. Without echo, we just cannot do anything, and that's the importance of the echo. And it is my proud privilege that the father of echo in India, Dr. Parashar's oration, has a wonderful combination of intervention and the echo, what the echo can play. And echo is not just an echo, it is a great tool to help us to get a better result, the best result for the children and the women and the humanity. And thank you very much for your kind attention. Thank you very much.
Thank you, Dr. Vijay, for the wonderful talk. As usual, that's what we expect from you. And you're like the Indian mother of children. You have so much serenity and calmness and the spirit of this place we are in, of Brahma Kumaris. I feel it all in you, gathered up all in you. So thank you very much.
Thank you.
Vijaya, thank you very much for, I will call it the high-end, highly sophisticated. Nothing can be done more in the field of pediatric cardiology more than you are doing. I really admire you for your work. I really congratulate the children of India, all India, on high-level pediatric cardiology that you have and all contributions to the field of pediatric cardiology. Thank you very much.
Ladies and gentlemen, I'd just like to give a final comment. Vijay is a young mother of pediatric cardiology in India. Let's give a big hand to her in this important oration in Bengaluru.
Thank you so much.
Thank you.